Welcome to the RETeval user group. We're excited that you decided to join us this evening, and we hope that you find tonight's conversation beneficial. My name is Gail Schwartz. I'm the Vice President of Marketing at LKC Technologies, and I'm excited that we offer this program because I think it's a great way for clinicians to talk to clinicians. This is intended for people who have the RETeval or trying to figure out how to maximize its utility, how to really make it beneficial in their clinic. And so tonight really is all about you. We have two optometrists who are going to lead this evening's presentation, and I'll introduce them in just a minute. But a couple of housekeeping things first. This is intended to be interactive. If you are happy sharing your video, share your video. It's so much nicer to see faces than little initials on the screen. If you have a question at any time throughout the presentation, you can do a couple of things. You can either physically raise your hand if your video is gone on. You can use the raise hand function at the top of the screen for Teams, or if you want, you can go ahead and put your question in the chat feature, which is also at the top of the screen. I have a couple of folks on here I'd like to introduce you to. Tori Locke. Tori is in the marketing team at LKC. She's kind of our monitor for a lot of things. Tori and I will be monitoring the chat throughout, and we'll throw questions to Dr. Bynum and Dr. Grant as they come up. I also want to introduce April Anderson. She is a clinical application specialist with LKC. She's here to answer any kind of questions you might have on device utilization, report interpretation, and just be a general support to the conversation. She is going to go over how to properly dock your RETeval before we get started. And then the other two folks I'd like to introduce are tonight's KOLs, Francis Bynum, who is out of Tennessee, and Dr. Bradley Grant, who is from Illinois. So without further ado, April, I'm going to turn it over to you if you want to just remind everyone how to properly dock their device, and then we'll let Dr. Bynum take over.
Perfect. Thank you. And this is something, just so everyone knows, that we always go over with your technicians whenever we do your install, is how to properly dock the device and how to get your reports off of it. But with the docking station itself, it has like the little cutout, like the little footprint that basically matches the RETeval device. But whenever your technicians are docking it, you just want to make sure that they're not going straight down on that docking station and shoving it in. You should just kind of naturally let it, fall back to that angle that it is cut out to do, and then gently press it down into that cradle. Because if they put it upright and they shove it in, there's little pins inside the docking station, and those little pins get broken, and it's a pretty expensive fix. So we always just like to remind everybody, we do it on training sessions, but then whenever we get together like this, just as, a reminder for you guys to make sure that your technicians, are doing it the right way. So that's all I've got.
I don't have a picture.
And your initials are on there. You don't have a picture of what?
I just have a circle with an F in it.
You're not seeing anyone? Do you have an option to change your view at the top of your screen?
I have.
We can see you.
I have my picture at the bottom on the right, and then I saw somebody else's picture in here earlier, but I don't see it now. Yeah, I see Matt's picture now.
We can see your picture.
Okay.
We can see you.
Someone's recording the meeting. Someone is outside here.
Yeah, and we are recording the meeting because we share it with everybody who participates and everybody who registered. So I'm hoping you're going to be able to see the presentation as Dr. Bynum gets started.
I'll just listen.
Awesome. All right. So Dr. Bynum, I'm going to turn it over to you, and I'm going to go silent.
Well, thank everyone for being on this evening. So we're going to start by talking a little bit about how do you practice. And through our conversations, Dr. Grant and I have incorporated the RETeval into our practices. So we'd like to talk a little bit about our protocols first and just the way we set things up. So we kind of came up with these 3 workflow variations, A, B, and C. And I think we agreed mostly on A is how we normally do things when we have existing patients, and C is for new patients. So Bradley, I think we'll start with you because this varied a little bit from how I was doing my protocol to you. But first, let's just kind of walk through first your why you bought the RETeval, and then how did you incorporate this into your workflow so it became easy, not only for you, but for your technicians?
Absolutely. Pleasure to be here and speaking with everybody. So thanks for having me, and always a pleasure to be with Dr. Bynum. Um, so when we acquired the RETevals, we acquired them in about June 2023. So we've had them for about a year and a half now. And it's always a challenge to incorporate new technology because, especially anything that takes longer than a couple minutes, you have to figure out how you get your staff to work that into the schedule. So what we did initially is we established certain automatic protocols, and those automatic protocols for us really fall into that workflow A. So the first automatic protocol is if anybody has a diagnosis of diabetes, really in any capacity. So that's an E1 1.9 diabetes with no ocular manifestations, any form of diabetic retinopathy, that individual is getting the test during the workup before they see myself or another one of our associate doctors. We have the same automatic protocol for AMD or drusen. And then actually we fall a little bit into the workflow C, which is conduct the exam, make a diagnosis, and then order the test for our glaucoma suspect patients, because usually if we're seeing any kind of optic nerve pathology that resembles more pallor than your traditional glaucoma, then we're going to order a PH&R. So for a few diagnoses, we have those automatic, gets the test no matter what. And then we have some that are ordered. And then how we actually integrate those tests and order them and review them, we'll talk about in a second. But I would say we fall heavily into A for probably 80 to 85% of our tests that we perform.
Yeah, I agree. I like to review the charts before I see patients. So I go through all the charts before for the day basically, and I instruct what test I wanted done. So when I acquired the ERG, actually the reason was really for diabetics. I see a lot of diabetics in my practice, and like many of you, patients do not just have diabetes, they do have glaucoma, they have macular degeneration, all these other pathologies that we see. But the why started with diabetes, and certainly it's expanded as I've become a lot more familiar with what information that I am collecting from running an ERG and how to use that to manage my patients. So I fall into A, where all of these people that have diabetic retinopathy are getting the ERG DR, where it's giving me that DR score. So then all of that's done. And then I'm still a little old school on the printout. Now, Bradley, I think we differed a little bit from this because I still there's two printouts of tests I still do in my office, visual fields and this particular one, because I like to sit in front of the patient. I actually circle their score, talk a little bit about what that score means and what our next step is in managing that patient. And occasionally I do fall into C as well, where I've seen the patient and I detect some type of pathology, or the patient's not seeing as I think they should see based on the structural findings that I see. So I might be incorporating C at that point, where then I order the test. But for me, it's become easy for my technicians to perform this test rather quickly, print it out, and have all that information ready when I sit down to discuss with the patient.
One of the things that you and I know agree on in terms of the testing, and I think we do a little bit different just based on some of the technology we have in the offices, but one is just the value of the patient education piece of the printout. For us, if we get into kind of the nuts and bolts of exactly how we facilitate that, one of the things that I know everyone on this call, I'm sure, is in a busier medical clinic, and that's kind of the nature of having devices like this. But we actually purchased a dedicated laptop at each office for the device. What we didn't want to be a point of frustration for the staff was somebody's on that computer on the EHR, or somebody's billing IMED claims, or somebody's ordering contact lens trials, right? We wanted to have a free computer that only does the RETeval. And so that way it's either docked or someone has taken the instrument. Another thing that we could talk about is, where do you do the test? We actually do the test in the exam room. So the patient is done with all the other pre-testing. We take the instrument into the exam room and perform it there. But then when they come back, that laptop, that dedicated computer is unused. So they can dock the device. We use Revolution EHR at all of our offices. And so we take the interpretation report, move that PDF into Revolution EHR's PDF upload, and then we can, in the exam room, access the test, and that way we can pull it up on the screens and go over the test with them in real time. So we've tried to put as many different structures in place, that way we don't get log jammed, right? Because a lot of times we're doing OCT same day, we're doing maybe visual field same day. And so we really found that, one, doing it in the exam room doesn't take up our workup testing area, and two, having a dedicated computer that only does the RETeval frees up that docking station, and we're not messing up workflow in other parts of the office. And when tasks build, to-do lists, build over and over and over again. So we've tried to streamline that.
I think that's
Dr.
a great.
Bynum, this quick question that came in, since you were talking about people with retinopathy. So the person said, if the patient only has E11.9 with no retinopathy, are you charging a screening to the patient, since the test cannot be billed to medical insurance?
So that's a fantastic question. Yeah.
Yeah, Bradley, I'll let you take that question.
Okay. So we're not charging a screening. You can bill it. So you can bill it. We know that it's not going to be covered. So it kind of depends. If there's truly only E11.9, and again, I think Dr. Bonham and I may touch on this, that many times there might be microaneurysms or something. Many times there also might be some hypertensive changes that are present. So if there's a little bit of vessel tortuosity, then we can bill that under venous engorgement. So many times there's codes that we could bill it under, but we're not charging a screening. We believe in the predictive value of the test. We believe in establishing a baseline early, and we'll talk about that a little bit as we get into the case. And so we bill it knowing that it's not going to get covered under that diagnosis if that's the case. And then if it comes back as non-covered or deductible, then we send the patient a statement. Again, we believe in the technology in terms of its usefulness in clinical decision-making. And so we try not to only perform the test if we know that it's covered. We perform the test because we believe it is necessary for taking care of the patient. So it gets billed the same way. Sometimes patients receive statements for it.
Yeah, I agree with Bradley. I think that is why we do things, is we're doing it to detect, monitor, and then appropriately refer when necessary. So E11.9, many times these people are, yes, in my clinic too, they are getting an ERG done. If they also have hypertensive retinopathy, that is a code that would cover this test. But I do it exactly like Bradley does. I bill that. I find a lot of value in these tests. I will say that, and I think most of us on the call, if you have wide field photography, you will say to yourself, gee, I missed some of those dot blot hemorrhages before I had wide field photography because I just couldn't see them. Well, now we have imaging that allows us to see things that before were, we'll just say, a lot more difficult to see. And that patient did indeed have retinopathy. I've had a few surprises where I thought it was a E11.9 because I didn't see any retinopathy. And then I end up doing a RETeval, and I think to myself, do I need to go back and look at something because structure and function weren't matching what I was seeing? Many times it's because they had such extensive capillary dropout. That's why I wasn't seeing the dot blot hemorrhages in that case. So to answer that question, yes, I do it just like Bradley does. I go ahead and perform that test. If it ends up it's not covered under their medical policy, then they'll just get a bill from us, a statement.
And I would double down and say that is part of the reason why I highly believe in the value of presenting the information to the patient, right? Most of the time, if you've demonstrated the findings, if you've talked about the importance of the DR score and its predictive value and how it relates to progression, you all know this. Sometimes patients are going to get upset if they have a bill in the mail for $2, but I think that it certainly makes that easier if the patient understands the level of care that they've been given, and at least know exactly what that test is that they're getting a statement for. So we always are making sure we're spending the time discussing the findings, and that helps us, I think, with potentially patients who might be upset about it.
I agree. One thing to just add about the workflow is we do a lot of testing, just like many of you, OCTs, photography, that sort of thing. So we have a bit of a strategy is whatever room that patient ends up in, where I'm going to go see them, that is the room where the RETeval is done. So that's usually the last thing that's done before I actually see the patient. So they don't have to move to another room. This is one nice piece of equipment that because it's portable, then it can just be taken into the room, done that, and then the tech is actually finished with the patient at that point. And then it might be a case where I'm ready to see the patient while they're actually docking it and printing it out for me. And Bradley, you make a really good point about going over things with patients. This is why I still print it out and I go over with it, because I think people see value in things that when we show them exactly what clinically we're looking at, what it means to us as a clinician and what it means to them as a patient.
Absolutely. One other twist to that I would say, not necessarily based on patient demonstration, but another workflow that we've started trying to evolve, because like you said, Dr. Bynum, many times we're ordering the RETeval, an OCT or a photo and a visual field on the same day, especially those that have active retinopathy. We want all the levels of structure and functional testing that we can get, but that certainly creates quite a lengthy amount of time during workup. So we have multiple locations, so we don't necessarily always have a doctor in those offices every day. So what we have marked out time for are testing only appointments. And so sometimes if we know that it's going to be a lot of time in workup, we might schedule 2 appointments for that individual. We might have them come in a week before to get all of the testing done, to get the RETeval done, to get the visual field done, to get the OCT done. And then whenever they're actually in clinic to see the doctor, then all of that is done. We have the information that we can review with them. But from a workup standpoint, whenever it's a busy clinical day, now they're just your normal acuities, pressures, history, that kind of thing. And it really speeds up the process. So I think sometimes if we're finding that it's hard to implement in our day-to-day workflow, it might be worth considering marking out time on our schedules specifically to get some testing done that takes some time, and then have the patient back in a more streamlined fashion for when you're in a busy clinic.
I think that's a good point that you make, because if you think about how primary care does a lot of things, they actually have patients come in maybe a week prior to actually do their blood work. So then when they come back to see the doctor, that is already done. So then they can go over that with the patient. So I think each office has to figure out what works best for them with their staff, with their technicians, coming together as a team, kind of looking at it as a team approach. What's best for the clinic and the clinic's time, and what's best for the patient and the patient's time. So I agree that there can be some value to having a patient come in and doing imaging, doing tests such as visual fields, ERGs before the actual day that you see the patient, and then you can review that before you ever walk in to see the patient. I think that can be very valuable. One other thing I'll mention is ordering tests. So you always have to have a reason to order a test. You can't just be doing tests to be doing tests. So it's really imperative in your notes, your documentation, that you order the test and why you order it. I'm ordering an ERG to monitor diabetic retinopathy, or I'm ordering an ERG to monitor hypertensive retinopathy or whatever, you can fill in the blanks. If I've seen a patient and they have retinopathy, I'm bringing them back, let's say 6 months, I go ahead and write my orders for whatever that day was that I did. But then I have when they're coming back. So I'm going to see Miss Jones back in 6 months. And in 6 months, I would like her to have perhaps an ERG. And I also want her to have an OCT of her macula and maybe OCTA. So I go ahead and write those orders for when I'm going to see Miss Jones 6 months down the road. So one of the questions that is commonly asked is, are you doing tests before you actually order them? The answer to that is no. I'm ordering them when I'm last seen the patient. I go ahead and order that patient for that order those tests for that next visit. And Bradley, is that how you're documenting that in your software as well, to order those tests for the next visit?
Yeah, that's exactly how we do it. With the amount of pathology we see, I'm really hyper particular about my documentation, and we'll have it multiple times in the plan, in maybe paragraph form, and then even line item in terms of that specific test being ordered. And one thing I would say in terms of working on the protocols, I mentioned at the beginning we have automatic protocols that we do, but the reality is it takes time. It wasn't like we turned a switch on and then the staff were ready to do the test on everybody, right? And so we had automatic protocols that we started with. Maybe in the first month the staff get 50% of those done, and then we have to have conversations about how we want to do it on this condition. At the same time, we're ordering it in our plan. The next month we're a little bit better, the next month we're a little bit better. And so I think it's really a 3 to 6 month process of implementing the education with the staff in terms of when you want it, for sure. But then at that same time, you're getting those 6 month patients back that you've already previously ordered. So when you get 6-8 months down the road, then it's really snowballing, because you have those automatic protocols that the staff know they're going to do before asking you, but then they're also looking in the chart from the previous diagnosis, previous plan, and they have line item orders that they're doing. And so it's a process. It's not something that happens overnight, but you kind of have to be committed to saying, this is when we're going to run the test. And you'd be surprised how quickly that snowballs into efficiencies with the staff.
Agree. And, it's really a team approach for probably all of our practices. And that team approach is from the front desk to the technicians to us, the doctors, to check out. It's a team approach. And when we develop protocols, and yeah, they don't develop overnight, but when you develop protocols and you have a very systematic way of doing things, and you incorporate your entire team and their input as well, when your tech says, hey, I think this could be a better way of doing things, this could make workflow better, a team approach sometimes makes our lives all a bit easier. And at the end of the day, the way we train our staffs to do the testing and to be able to tell patients the why behind what we're doing, I think that's very important. A very important part of developing that protocol is training your staff into telling the patient what they're fixing to do and that why behind it. And then the comfort level with staff. For me, all of my technicians are trained to do this particular test. I find that it's pretty easy for techs to learn how to do this test. And of course, every now and then, I don't know about you, Bradley, but every now and then I have to do it. It puts a little sweat on my temple, because then I have to remember exactly how to place those electrodes properly. But everybody knows how to do it. And I think everybody's very, very efficient at doing that. Unlike some other tests, sometimes you have one test that one tech's a little better at, but I would say this is one that I felt like all my staff are pretty even par on doing a very good job of the test.
So I'll only say this because we're amongst friends and this is a safe place. I've actually never done the test, but
Oh my goodness.
So I
Tomorrow, that's what you have to do.
all the more reason why we tried to establish firm protocols. But I do have a question for you. Do you traditionally try to, when you have an interesting case with a patient, do you traditionally try to pull that staff member aside after the patient's gone and show them the findings so that they can kind of see the why behind it, and really kind of build that confidence in the test, and like you said, the team approach that you talked about?
there's always kind of aha moments that we have all had in practice. And this is not when I say it's a good story, it's a good story from a staff learning. But I had a patient that we did an ERG on. It wasn't a diabetic patient. It was we'll just say a very strange variant of retinitis pigmentosa. She had only trace bone spicules. So we did an ERG on her and it flatlined. Well, the tech thought she had done something wrong. She thought she had put the electrodes in the wrong place because she kind of knew what they were supposed to look like. She knew what those waves were supposed to look like. So she actually went and got one of the other techs and said, I think I did the test wrong. I mean, she'd done it quite a bit. She thought she had done it wrong. And the tech took one look at it and said, the other tech said, well, I'll just go redo it. So the electrodes were still on the patient. So the other tech walked in there and said something to the effect of, Dr. Bynum just wanted a different test, so I'm going to just do this other one. Well, it was the same test. The patient just didn't know it. Of course, it flatlined again. And then the tech came and got me and she said, I think I did something wrong because it flatlined. Well, no, it really did flatline. So that was a huge learning curve and an aha moment for my staff. Well, then fast forward probably 3 months down the road, I had a patient that was going for cataract surgery, but his cataracts really didn't match. I mean, his cataracts looked equal to me, but his visual acuity didn't match. So we did an ERG on him. Well, one of the, I think it was his right eye, the peaks were very, very low and the other was perfectly normal. Well, then that staff member felt very confident. She actually made a note on it for me and said, yeah, something's going on with this patient's right eye. So then she had that confidence to know what she was seeing. So I think, yeah, so those cases that are interesting, those cases that are out of the norm, I do like to bring staff members in and sometimes it's part of a staff meeting where we do some training about, this is what we saw. This was the why you saw this, why it was different. So I think staff education, you cannot stress that enough, how valuable it is to our practices, where when they recognize something, I think we've all probably had techs that did photos. They didn't know what they were seeing, but they knew it wasn't normal and they came and got us. So I think things like incorporating that into teaching moments like that with our staff is invaluable. It helps our workflow too.
Right.
Because sometimes it just doesn't bog things up. Like the day that the ERG was run twice because the tech thought something was wrong, that it wasn't wrong. So I think taking those times for those teaching moments can be invaluable in our practices.
So you touched on one small point there that I would recommend everybody tell their staff is that you mentioned that the electrodes are still on the eyes. We actually do that when the staff leave the room to go to the docking station, right? There's steps that have to be taken from docking it to pulling the PDF over, and once in a great while something gets lost in translation. Maybe they didn't dock it well, maybe they fat fingered something on the device and erased the test instead of sending it over. So we've basically instructed our staff to say, you can leave the room, leave the electrodes on. When you see that PDF has successfully pulled over into the EHR, now you can go and take them off, because you can always redo the test, but you take the electrodes off, then you've burned that set of electrodes. So it doesn't happen that often, but we had it happen enough to where we started saying, just make sure that it is either printed or the PDF is visible before you take those electrodes off. That's
a very good point, because, and I'm going to remind my staff of that just because you brought it up tonight, just to remind them of that you just don't want to waste those electrodes. So
we actually have the patient leave them on through the refraction, just because they like them that much. But
they come on a little clear plastic piece too, just so you guys know. So if they really technically if they were irritating for whatever reason, they could technically take them off and replace them back on that little clear plastic piece. And I have some practices that will do that. Like they'll have like just a manila folder with a router that goes with the patient from room to room. It's like a paper clip on it, and they'll just put it underneath that paper clip. So those electrodes are with that patient until they're actually checked out and getting ready to leave, and then they toss them, just in case for whatever reason you needed to replace them to retest.
Yeah, that's a good idea. I don't know that we have that happen very often, where they actually take them off. Usually the tech goes, prints the report out for me, and then they come back and take them off the patient. But I do know the techs do a very good job of asking the patient to just leave them on. So but that's a good point, just to remind our staff about that. So any other questions about workflow that we have before we move on?
Dr.
So-
Bynum, I'm seeing a couple questions in the chat about billing, a couple other things, but I want to make sure that we have time to present our cases because I think some of these may get answered organically, and then we may also have time at the end.
Okay, well, let's move on because we have a great case that Bradley's going to present. So we'll go through this case, and Bradley, I might have some questions along the way, and if anybody else has questions, put those in the chat, and then hopefully at the end, as we wrap this up, we can answer some of those billing questions.
Fantastic. Yeah, actually, I selected this case somewhat anticipating some of the billing questions and somewhat anticipating why we have the protocols that we do. To me, this was a really good case in terms of demonstrating the consistency of the DR score, but also the specificity and sensitivity of the test. So this 73-year-old Black male had a history of moderate non-proliferative in the right eye, severe in the left eye. We were also treating him for glaucoma as well. So we were seeing this individual on a 6-month interval. We were doing, before we acquired the RETeval technology, we were doing serial visual field testing. We would alternate 24-2 visual field testing and 10-2, given that they were both had diabetic retinopathy and glaucoma. So that when we first saw him after acquiring the RETeval technology was in August 2023. And then that's when we had diagnosed the not moderate and the severe. That was not a change. And then the second test that you'll see here in a minute is in March 2024. So when we saw him in August, it was fairly stable. Again, the Optos doesn't show up great on the screen here, but if you could see the level of hemorrhages, moderate in the right based on not having all 4 quadrants with severe hemorrhages, not venous beating into consecutive quadrants, and not having any IRMA. Left eye does have more significant hemorrhages in all 4 quadrants. And so at this point in time, from the photos, did not have macular edema. At this visit, we were scheduled to do the 10-2 visual field testing. We were alternating those 10-2, 24-2 based on concurrent diagnosis of diabetes and glaucoma. Relatively unremarkable in terms of the visual field testing. We traditionally get an OCT every time, whether or not we bill for the photos, especially if they have diabetic retinopathy. But the biggest thing to see, and it kind of stands out pretty plainly here, is in August 2023, we did not have macular edema. We did have severe non-proliferative, but we did not have macular edema. And then in March 2024, when we saw this patient back, you can see just superior to the fovea there, we do have swelling and some macular edema present. And as we remember, you can have macular edema present at any stage of non-proliferative diabetic retinopathy. And so if you keep those 2 OCT images in mind, and we look at the 2 RETevals, again, August 2023, we have a DR score of 20.6. March 2024, just with that little bit of change in terms of cellular stress, also the addition of macular edema, you can see that DR score did jump 0.3 points. And so is 0.3 points significant? I think it is. Again, you can see you're not gonna be able to see the numbers on that, but the biggest thing that influenced the change in the DR score was the increase in latency in the 2024 versus the August 2023 RETeval test. And again, that signifies cellular stress when you have an increase in latency, left eye as compared to 6 months earlier. The reason why I thought this case was significant, if we can go to the next, is if we remember the Brigel study, and that's really kind of the landmark study why we base our protocols on. The finding that I think we're mostly familiar with is that the significance of the DR score being over 23.5. And if we remember, individuals who have concurrent severe non-proliferative diabetic retinopathy, as well as a DR score over 23.5, then those individuals, 67%, are going to progress to needing retinal intervention within 3 years. But the second arm of that study, or the second finding of that study, was how much a small change in DR score makes in terms of elevating the risk factor. And so it showed that just a 1-point change in the DR score increased the risk by 28% over that same 3-year period, same endpoint in terms of needing retinal intervention. You can see some of the more significant findings, right? You're tripled with a 4.5 increase, you're 12x more likely with a 10-point increase. Again, I think we can both agree that if we see someone with a 10-point increase in DR score, the wheels have certainly fallen off in somewhere. So those are no-brainers. But for me, what this shows is the significance of establishing a baseline. Right? I think about diabetic retinopathy and really just diabetes in general in the same way. It's a chronic progressive condition. We want to establish a firm baseline sooner rather than later. All of us, if we have an individual that we deem as a diabetic or as a glaucoma suspect, we're going to get a baseline OCT to reference against. We're going to get a baseline visual field, gonioscopy, pachymetry, fundus photos. In the same way, the reason why we do this test automatically for anyone with diabetes is I want to know what that baseline DR score is, because we know that if that DR score is increasing over time, then the risk factor is increasing at a pretty alarmingly high rate along with it. If we go back to our particular patients' DR score, you'll notice that they actually fall in that category of not having a DR score over 23.5. And so the same study showed us that 18% of individuals fall in this category where they have severe non-proliferative changes, but a DR score under 23.5, and 18% is still a pretty significant number. So again, the increase is important, I think clinically and backed by the study, but also just establishing that baseline structurally and functionally is very important for patient education, patient compliance, and clinical decision making. So anyway, that's why I presented that case.
I think this is a great case because it really shows numbers do matter. And sometimes we don't know what that score was prior. So we have two numbers here, but in your mind, don't you sometimes think, I wonder what that number was prior to that? And so we can know trends and we can know the direction in which people are heading, because we all have patients that have DR scores of 20 and we think that's great, but were they at one point 16 and then the next time 17 and then were they 20? So I think understanding trends, it's really that same concept of when we look at IOP with glaucoma patients, understanding trends and knowing what those mean. I also would say, if you look at the 20.3, you're thinking, oh, that's a good number. But I think clinically you do have to step back. In this case, what I really like about this case, Bradley, that you brought is that this is a reminder of how you look at all of the things. You're not only looking at wide field photography, you're looking at a visual field, which the visual field wasn't that significant, and then you're looking at the OCT of that retinal edema that the patient has. And then you're using one more tool to say, yes, this patient is progressing and understanding that risk. So, but let's say, could we use an example here? So this was a great case and I do love this, but I think, Bradley, one of the things that you and I talk about is how we should manage patients. So not this patient, but let's just say a patient that we see that has, we're going to say mild diabetic retinopathy. We see a few dot blot hemorrhages, and we have that patient that has retinopathy and they have a score, let's say less than 20 to 23. Are you typically bringing that patient back at a 6-month interval?
Yes. So if they have what I would call, and based on the Bruegel study, they term it structural changes. They define structural changes by an ETDRS score of 53 or less, which I have no idea what that means, short of looking it up, but it basically means severe non-proliferative. And so if I see anything moderate or mild diabetic retinopathy or less, and a DR score of less than 23.5, then I'm likely seeing them every 6 months. If
Okay.
I see severe, or what would be defined by structural change, severe non-proliferative or worse, or moderate and a DR score over 23.5, I'm actually moving that up. I'm going every 4 months with that individual. In this particular case, he did have macular edema. So we did send him to retina, and he has been receiving intravitreal injections and is doing better. But if this individual had just had an increase in DR score and not the associated macular edema, what we would have done is moved up the interval in terms of follow-up and testing, and not referred him out at that point in time.
Yeah, one of the pieces of the puzzle that I like to think about is how we have approached diabetics and diabetic retinopathy just in general is when we saw, let's say, early or mild retinopathy, sometimes, you had to put that OCT with it, and the OCT is normal, and you just, whatever the fundus photography shows you. I think this is one more key to that, of understanding how frequently we should see patients. And for me, I'm looking at that DR score to see how it's increasing. And if I'm not seeing that structurally, I might be a little bit conservative. But on the other hand, as the DR score increases, that 23.5, kind of that magic number, as that gets closer to that, I explain that to the patient as they become more and more at risk for needing maybe a retinal intervention. And stressing to a patient that early intervention, no matter what we're talking about, is always the key. When we talk to some of our colleagues, I think there's two things, Bradley, that keep some of our colleagues up at night. And it's, did I diagnose someone quick enough and get them to retina? Whether we're talking about diabetes or macular degeneration or other things. And I think there's more and more tools out there that help us know when to correctly refer those people to retina. I think OCT technology brought that into light as well, and it helped all of us. So we didn't stay up at night. I think this is just one more tool of using a DR score and understanding the DR score, understanding it and knowing what these risks mean is making us or enabling us to be able to refer to retina in a very timely manner for patients to get treatment. Like this case certainly is an excellent case of knowing you really helped a patient to get them to retina appropriately and timely, so hopefully they don't have vision loss. And of course, this case was complicated probably by glaucoma as well, but right. I think if we can do something to help us understand proper referral and what these scores mean, it's a help. So let's touch a little bit on billing. I think there was maybe some questions about that. So so for this particular patient, do you want to walk us through your process of billing for this patient?
Yeah, so each time that we see this individual, again, I believe that he was a commercial, I think maybe the first time we saw him, he was a commercial plan, and then crossed over into Medicare the second time. So we coded it a little bit different each time. So for each office visit, depending upon if it was a commercial payer or a Medicare payer, we would do either a comprehensive 92014 or 99214. That's off into the weeds of a 6-hour conversation about where we chose those, but we do a comprehensive medical office visit code. Each of the times that we're seeing them, if we're doing a visual field, an OCT, or the ERG, we bill those all three, 92250, 92083, 92273. And the nice thing about this test is that it does not require modifiers. So you can do it on the same day as other testing, but it doesn't necessarily require a 25 modifier on the exam, which is common sometimes for testing, punctal plugs being one example, epilation being the other. So the billing is relatively straightforward, but we're always doing comprehensive exam and testing. And as far as the coding is concerned for those tests, he has multiple diagnoses that would be covered, diagnoses for the test. He has diabetic retinopathy, he has retinal hemorrhage, he has macular edema. All of those would be an ICD-10 that for any payer that we've billed to or am aware of, easily cover those. So really didn't have any trouble with the billing on this side.
When I looked at this case, if I was thinking about billing, it's a 99214 in my book, along with obviously the visual field code, the ERG, and the OCT. Just remember, you can't do OCT and photos on the same day. ERG doesn't have that. You can do any of those on the same day. It's just OCT and photos cannot be billed on the same day. So hopefully that answers billing questions. The other is frequency. So frequency is typically determined by your medical decision making. So in this particular case, I think that, doing it at a 6-month interval is adequate. I even would challenge, if you would have said, when you presented this case, if you would have brought that patient back in 4 months, I would have said that would have been maybe what I would have done. Actually, I probably would have brought the patient back in 4 months because they were a glaucoma patient. But I think determining frequency of testing is your medical decision making. I don't think you could do an ERG 4 times a year if the person just had mild retinopathy. However, someone that is showing progression, and one of the things I'm going to applaud you when you put this case together is sometimes we get a little, I'm just going to use the word complacent, and sometimes when we are coding, we just say, oh, both of those are moderate diabetic retinopathy, but you broke them out because one definitely was severe and one was moderate. And I think from a coding standpoint that we need to be, all of us need to be better at coding and make sure that we're properly coding right eye and properly coding left eye. But when it comes to frequency of how this particular test can be done, it's really up to you and your medical decision making how frequently you think it should be done. I think most of us out there, when we've talked, Bradley, when we talk to other peers, most of us are doing this test every 6 months on our retinopathy. People that have diabetic retinopathy, sometimes maybe a little bit more frequently if it's more severe.
I'd say the most frequent, or the most times that we've done any particular RETeval or ERG test would be 3 times for any individual. We have seen sometimes that it requires resubmission to payers. In fairness, some payers are still kind of learning the codes. We have certain commercial plans that sometimes will kick it back for ones that will traditionally be paid by Medicare or your standard commercial payers, and sometimes we have to change the diagnoses. But we also have individuals that have multiple conditions, and so we might be running 2 DR scores a year or 2 DR protocols and maybe 1 PHNR because they also have optic nerve pathology. So the most we've ever done for any one particular patient has been 3 times in a 12-month period. And to my knowledge, I don't necessarily dive into every single EOB, but I do enough to make sure that I'm aware of the trends that we're seeing. Most of the time when it's a denial, it's more about an ICD-10 code for a certain payer, more so than frequency. So I haven't seen that be an issue for us.
Yeah, I haven't seen, and again, 2 is probably more of a standard.
Yeah.
3 maybe is an occasional one that would be done 3 times a year. And then there's a lot of them that we're just doing, on an annual basis. But we, from my standpoint, we haven't had any problems getting paid for this. And it all starts with coding correctly. But we haven't had any problems getting paid by any of our carriers, whether it was Medicare or it was any of the commercial carriers. Occasionally, they want notes, but again, I think that's your notes should speak for itself on why this test was indicated. And I'll just make one other comment about, don't forget that this is a test that you order. You have to order the test, give a reason why you're ordering it. Patient has diabetic retinopathy. And don't forget, you have to do an interpretation and report as well. So you have to state about your findings. I mentioned I'm a little old school. I like to print it out. And so I like to circle that DR score. And I always make a comment, especially if they've had one prior, what the trend of that DR score is. DR score has increased, DR score stayed the same. And I might also write some verbiage about if the DR score had doubled, about what their risk, how that applied to their risk of needing a referral. And that all might be written in my interpretation and report as well.
Yeah, if you don't document it, you didn't do it. I mean, basically based on the insurance
Right.
data, you know, that's what we've
Right.
kind of come to practice based on, is if it's not all three of those points that you talked about, ordered, reason for test, interpretation, in an audit, you didn't do it.
Right. And I think too, when we, and I think all of us are big on patient education. And when we sit down and we take that extra few minutes to explain to a patient that their DR score has gone from 18 to 21. So they've had this increase in their points. You're showing it to them. You're showing them the printout. And I'm usually writing sometimes while I'm going it over with them right in front of them and saying, you know, increased DR score. This is increasing their chances of, you know, significant retinopathy where they would need a referral. I just write that out right in front of the patient with them sitting in front of me. So it's my thought process. So then next time I do that, the patient, you know, expects me to do the same thing. I'm going over those scores with them. So I think that's one way you can not only meet all those measurements that we have to do from a checking the boxes with your insurance companies, but doing right by your patients too and educating them.
Absolutely.
So I think we have just a few minutes left. Do we have any other questions?
I think I saw one about the PH&R score in terms of documentation, if I saw one come across. How do I document PH&R? When that test is performed, I actually document an assessment of each different branch of it. So I'll assess A wave, B wave, and PH&R. I'll also document whether or not it's a baseline or if it is any progression. So actually we have reason for test, or the ordered test, reason for test, and then we actually piece out each of those A wave, B wave, PH&R in our you know, right eye and left eye in our interpretation area in the EHR.
And just don't forget, you cannot use, when you're billing the ERG, you cannot use glaucoma. You have to use the code for glaucoma atrophy or optic atrophy. You have to use those codes. You can't use the H40 point, whatever glaucoma they have. You have to use the atrophy code. Any other questions out there?
Dr. Bynum, we have a question in the chat. I know you touched on this a little bit when you said you would circle results with the patient, but can you just expand on how you walk a patient through the numbers? Do you generally talk in big picture? Do you kind of tunnel down into the data with them?
Well, some of that's just knowing how to read your patient, knowing what kind of information that they want. It all starts with my staff, because my staff, when they do the test, whether they've done it one time on the patient or they've done it several times, they always kind of make a mention of, oh, you know, this is kind of like an EKG, you know, those waves that you see that they do on your heart. So the patient has that mindset that this is a wave. And so they already have that mindset, but I sit in front of them and then I just talk numbers and I talk about what those numbers indicate to me and what trend that they're making. So some patients I might go a little bit more into depth. If they have a decreased amplitude, then obviously that's their retina is, you know, they have some cell death in their retina. If they have just delayed time, a timing delay, sometimes that might just indicate more of stress on their retina. So a lot of patients, I don't use really technical terms. I put it in just everyday language of, this indicates there's a lot of stress on your retina, which then can lead to death of retina, which ultimately leads to vision loss. And that's where we want to intervene. So that's probably my conversation that I have with the patient, but I'm always circling the number. And if they've had the test done prior to that, I'm telling them what their numbers were prior to that.
Any other question themes that you've seen come across the chat box there?
Yeah, let me see here. There's one that says if you have patients with HTN and you document hypertension at attenuation, is this a medical justification to do a 16 TD on all those kinds of patients?
So would you say that, I guess, if it's a hypertensive retinopathy, and so just to maybe break that down a little bit in terms of when I would document hypertensive retinopathy, if I see, AV nicking banking, if I see venous tortuosity, any of those signs, certainly if I see flame hemorrhages, I'm going to document that, the findings in the chart, and then I would actually put the ICD-10 of hypertensive retinopathy on the plan or the assessment section. And yeah, that's 100% a justification for doing the Flickr 16. And we've billed that, multiple times, and to my knowledge, been successful in terms of reimbursement for that. I usually will, one kind of coding nuance is that I'll usually put both so take, for example, the diabetic, let's just say moderate non-proliferative diabetic retinopathy in the right eye. I have found that sometimes it's goes through the first time better if we also have retinal hemorrhage on there as well. So we know that there's retinal hemorrhage by nature of it being moderate non-proliferative, but sometimes if we just bill it with the condition itself and not the finding, we get it kicked back for needing a more specific diagnosis code. So in that instance, if you're seeing, let's say, tortuosity that has defined hypertensive retinopathy, it might be easier, better luck the first time submitting it to put hypertensive retinopathy, right eye, left eye, or bilateral, and venous engorgement. But that may be going into the weeds a little bit, but I don't know if you've maybe experienced that, Dr. Bynum, but I like to put the exact finding as a standalone ICD-10 as well as the global condition. Tends to work great.
I probably would just use the hypertensive retinopathy code. I haven't had any problems with using hypertensive retinopathy and getting paid for that. I haven't had to go into more extensive. However, I will say if I see certain types of hemorrhaging associated with hypertensive retinopathy, sometimes I do use those codes as well. And I'll expand a little bit on that too. If I'm doing this on a patient who's hypertensive, from educating the patient point of view, I use that same analogy of what the amplitude and what the time indicates to me. So if it's a delayed time, I might indicate to the patient that, your blood pressure has effect on your whole entire body. It doesn't just affect one thing. It can affect your eyes as well. And this is indicating to me that your eyes are a bit sick. Maybe they have metabolic stress, that sort of thing. And so I go into that a little bit with patients too, because people forget things like high blood pressure do definitely affect their eyes. Because I think at the end of the day, people are judging their vision based on one point, and that's that macula, I see 20/20. So I'm fine.
Mm-hmm.
So I think it's our job to sometimes expand on that a little bit and educate them about why they're not fine and why we want to monitor them. Pictures do a great job as well. Showing pictures of, crossing changes, flame shaped hemorrhages, all those sort of things are great as well. But sometimes it's the power of words of, I know your vision's 20/20. However, this is our findings. Any other questions out there in the chat?
Yeah, there's a couple. I mean, here's one that says for dry ARMD, is it appropriate to perform a 16 TD on this machine versus other types of ERG testing?
Well, this is just my opinion, so Bradley can chime in with his opinion. So for someone that has macular degeneration, so full field ERGs, that's what this is full field. So it's looking at the entire retina. Remember, AMD sometimes is just very limited to a very small portion of the retina. However, I think one of the things that we have to begin to think about or understand about macular degeneration, it could be more widespread, because what about all those peripheral drusen that you're seeing? So it would be interesting to know if a patient had macular degeneration, how much the peripheral retina played into that. By in doing a 16 TES certainly can give us valuable information about the overall function of the retina. So yes, I think it's appropriate. I think that doing this type of testing, when it becomes more and more routine on lot, and I shouldn't use the word routine, but it becomes more common on all these diseases that we see, maybe we begin to learn more and more. Certainly, I'm going to go a little old here. OCT technology wasn't available when I was in optometry school. Wow, have I learned a lot about the retina, but I've also learned a lot about the choroid as well, because who knew that a thin choroid created anything? So I think that the more testing is done like this, looking at full field ERGs, becomes, maybe we become better at understanding some of these things that we're seeing. Bradley, you want to chime into that? Do you do that
Yeah.
on AMD patients?
We do. So the reason why I think it's important is because in the realm now where there's an importance in dry AMD in a specific subset of geographic atrophy, right? For referrals to our retinal colleagues for potential intravitreal injections of some of the medications that are approved for geographic atrophy. Those are larger areas of retinal disease, retinal atrophy, and so yes, it is a full field ERG, so you're getting a lot of potentially healthy retina in the periphery. But I do think that if that's another piece of information, a lot of times we're on the fence on those individuals. We have the OCT findings that might indicate early forms of geographic atrophy. We have visual field testing that we can look for progression. But again, it gives us that other piece of information in terms of clinical decision making. Is this truly progressing in terms of a form of cellular stress? And does that make sense to maybe have a conversation with our retinal colleagues about potentially some of the newer treatments that are out there for specifically advanced forms of dry AMD and geographic atrophy? So with the advent of those technologies and those treatments, and hopefully further developments coming down the line in not too distant future, I think it's important to be able to find any means of functional progression, and so that's why we've elected to do it for that. We use Flickr 16 for that.
Yeah, well said. Well said.
Dr. Bynum, we have a Dr. Greenstein that has his hand raised. Dr. Greenstein, if you still have a question, you want to unmute yourself and ask it? All right, one last question while he's trying to figure out if he can unmute himself. Let's just do this last one and then we should call tonight since we're running over. The last one that came in says, when we see significant cellular stress from slow implicit speed and we don't know what is causing that stress, how do we present that to the patient and what direction would we take with that information?
Bradley, do you want to take that one or would you like me to take that?
Yeah, I'll start and then I'll let you.
Okay.
I'll deliver the low level stuff and I'll let you drive home the real point. How about that? So I think it kind of depends on what condition did you do the test for, right? And so if you're seeing cellular stress in the form of AMD, then that might change your treatment protocols. It might change your follow-up schedule. If it's for diabetic changes, then I think maybe that speeds up your follow-up schedule. If it's for PHNR and glaucoma, then maybe that means that you should get more frequent visual field testing or dive deeper into some structural or functional testing. And maybe that means that there's cellular stress that's happening that would warrant additional hypotensive medication. So I think it's just something you have to pay attention to depending upon what condition it is that you're testing, and let that guide your follow-up, retest, and potential treatment strategies based on those findings.
Yeah, I totally agree with that. The only thing that I would add is, or kind of expand on, that there are times when things don't make sense to us. So a patient comes in, maybe the lens looks fine, the cornea looks fine, the retina looks fine, the nerve looks fine to us, but their acuity is not, or their complaints of, where they're at, and you end up doing an ERG, and it shows you decreased, maybe decreased amplitude or a latency in the time. Then you begin to think, yeah, there is something wrong with this retina. And then it's our job to just go investigate. Maybe that lends us, just like Bradley said, to the next test, to the visual field or some other type of testing. But I think when things don't make sense, we have to begin to figure out the why behind that. And certainly this can be just a piece of the puzzle that makes us look at certain things, whether it's a PHNR, the A wave, the B wave, looking at that, trying to be, we're detectives, right? At the end of the day, we're just detectives trying to solve the mysteries. So I think we just look at those things and just clinically use that knowledge that we have, and then use the tools that we have to monitor things, to detect things, and then to detect progression or change in things.
Thank you, Dr. Bynum, and thank you, Dr. Grant. Just a reminder to everybody who was on here tonight, we appreciate you spending your evening with us. You will get a recording of tonight's presentation, and there were lots of questions asked and some resources that we will provide to you along with that recording, including our interpretation report form that kind of can guide you through what you should be documenting. We have a billing and coding guide. There's always questions on billing, and we know a lot of that's open to interpretation, but that provides some really useful information. We have a guide to common protocols. That's just a good reminder of, when you're seeing certain symptoms, which tests should you run, and what are the possible codes that you could bill for that. And then we're also some other questions related to diabetic retinopathy. So I'm going to include our modern fundamentals, which really gives some background on what some key folks in the industry think we should be doing for diabetics and to better diagnose and manage diabetic retinopathy. So please look for that. You'll probably get that in the next day or so. And again, thank you for coming, and thank you, Dr. Bynum and Dr. Grant.
Thanks for having us.
Absolutely.
Good night, everyone.
Yeah.
Good night.